Hi, I'm Joe Graydon.
I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy, where we bring you the stories behind the health headlines.
This podcast is brought to you by Redix Industries, makers of Utterly Smooth Body Cream. 800-345-7339, on the web at uttercream.com. The cholesterol controversy has lots of people confused. Should everyone be taking a statin-type cholesterol-lowering drug? This is the People's Pharmacy with Terry and Joe Graydon.
Health professionals have worried about cholesterol for decades, but not all experts agree that it's the primary driver of heart disease. Could statins be working in part as anti-inflammatory agents? When are these drugs most appropriate?
Two cardiologists present differing perspectives on the benefits and risks of statins. What are the side effects of these medications? Is diabetes too rare a reaction to be troublesome, or is it a worrisome complication?
Coming up on the People's Pharmacy, find out what you can do to have a healthy heart.
First, this news.
In the People's Pharmacy health headlines, birth control pills may increase the risk for psychological depression. For 50 years, doctors have been wondering whether hormonal contraception could affect mood. A new study from Denmark suggests that the answer is yes. The researchers reviewed all the records for 1 million Danish women between 15 and 34 years of age between 1995 and 2013. They compared who got a prescription for a hormonal contraceptive and then analyzed who was later prescribed an antidepressant for the first time. More than half of the women used a hormonally based method of contraception during that time. Birth control pills were the most common, but women also used IUDs containing progestin, skin patches, and vaginal rings containing estrogen, as well as Depo-Provera, a long-lasting progesterone product. Teens appear to be especially vulnerable to the possible psychological effects of hormones used to avoid pregnancy. Those taking birth control pills were 1.8 times more likely than non-users to develop depression after starting the pills. Those using Depo-Provera were about 3 times more likely than non-users to get an antidepressant prescription.
Depression leading to suicide may be an unexpected risk associated with repeated infection. Danish epidemiologists examined the health records of more than 7 million people for 30 years. What they found is that people who have been hospitalized for the treatment of infection are 40% more likely to commit suicide. Those who have been hospitalized for at least 7 infections have a startling 300% greater risk of suicide. Even though suicide is uncommon, this association is significant. The connection with hospitalization and infection accounted for about 10% of the suicides that took place in Denmark during the decades under analysis. An accompanying editorial suggests that inflammation triggered by an infection may affect the brain and lead to depression. Some pathogens, including HIV and toxoplasmosis, seem to have particular affinity for the nervous system. The editorialist suggests that people with depression or suicidal behavior may need to be screened and treated for such infections.
Cheese is a delicious dairy product that's rich in saturated fat. As a result, the dietary guidelines recommend limiting cheese consumption to prevent raising cholesterol. Danish scientists conducted a 3-month randomized controlled trial to test this assumption. The 164 volunteers had at least 2 features of the metabolic syndrome. They were randomly assigned to a diet containing regular fat cheese, reduced fat cheese, or no cheese, just bread and jam. At the end of the 12 weeks, there were no significant differences in LDL cholesterol among the groups. Beneficial HDL cholesterol trended higher on the full-fat cheese diet. The researchers conclude, for most individuals, it's reasonable to include regular fat cheese as part of a healthy diet.
For years, experts have been arguing about the effect of meal timing on weight control. Some people skip breakfast while others skimp on lunch, consuming most of their calories in the evening. A new study suggests that they might be better served by eating a good lunch and going light on supper. 80 women were recruited and randomly assigned to a main meal at either lunch or dinner. This weight loss study ran for 3 months. The researchers found that the dieters getting more calories at lunch lost more weight and reduced their body mass index and insulin resistance. This preliminary research suggests that people trying to lose weight might benefit from a bigger lunch.
Researchers have been clashing over the benefits and risks of statin-type cholesterol-lowering drugs in the pages of 2 major British medical journals. While most physicians agree that statins can be helpful for people who have heart disease, they argue about the value of drugs like atorvastatin or simvastatin for healthy people. The BMJ has published articles suggesting that statins are being overprescribed for this group. Authors in The Lancet have written that this position endangers lives and should be retracted. Cardiologist Rita Redberg, editor of JAMA Internal Medicine, suggests that more focus should be placed on overall risk and a healthy lifestyle. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. We often assume that health professionals all agree about the best ways to treat common conditions. When it comes to preventing heart disease, however, there is some controversy. It revolves primarily around the most appropriate use of cholesterol-lowering drugs and how to weigh their benefits and risks.
To help us sort out these complex questions, we'll hear from 2 cardiologists with somewhat different perspectives. First, we turn to Dr. Sidney Smith. He's professor of medicine at the University of North Carolina School of Medicine. He's past president of the American Heart Association and served as chair of the executive committee for the National Heart, Lung, and Blood Institute, part of the NIH. Dr. Smith was responsible for shepherding the integrated guidelines for the prevention of cardiovascular disease. He also chaired the combined committee that drew up guidelines on secondary prevention for the American Heart Association and the American College of Cardiology.
Welcome back to the People's Pharmacy, Dr. Sidney Smith.
Thank you.
Dr. Smith, we have seen for some time now a controversy stirring over the treatment of heart disease, and specifically over a class of drugs called statins. And it came to a head not too long ago when a couple of major important medical journals published essentially dueling perspectives. So I'm talking about the BMJ, which used to be called the British Medical Journal, and the Lancet, which is a different British medical journal. But even though this controversy was published in England, it really is worldwide. And the controversy is this, as I'm sure you're aware, but perhaps our listeners might not be. There is a group of individuals who have run studies of statin drugs for preventing heart disease. They call themselves the Cholesterol Treatment Trialists Collaboration, and they are saying, enough already, just stop talking about statins and take them. Nobody, no doctors, no journals, no media should be saying anything negative about statins. And on the other side, there are physicians, responsible physicians, saying it's not reasonable to say just don't talk about side effects. Statins do have some side effects. We should be talking about how well statins work and for whom. So we are asking you today to help us figure this out.
Well, I'll try to do my best, Terry. My background and interest in this stems from my work as a cardiologist treating patients, and it's about 40 years of work, and that has led me to get involved in how we take science and derive recommendations from it, and these usually come in the form of guidelines. The past 10 to 15 years have been especially interesting because at the turn of the century, our Institute of Medicine issued a report saying that in its current form and habits and environment, the American healthcare was incapable of providing the public with a quality of healthcare it expected and deserved. They went on to say that we needed to make our decision-making more on evidence. Now, that led to my recruitment by the NHLBI, the National Heart, Lung, Blood Institute, to chair an effort to really look at the evidence. And this took place from 2008 to 2013, 5 years, over $20 million, 90 of the best people in the country working on 6 different guideline recommendations. And 3 of them are, I think, pertinent to your question and to the issues today. One was, what do we know about assessing risk? How can we figure out who is at risk and who we really ought to be focusing our treatment strategies on? Secondly, what do we know about what we should be eating? And thirdly, what is the evidence for treating individuals that may be at high risk? And the results of this were also somewhat interesting and somewhat disruptive because they challenged the idea that we should be treating a cholesterol number, that all you need to know is your total cholesterol and then you should start treating it. We found that there was no real evidence about supporting treating to a target number of 70, which was the LDL cholesterol that previously was recommended where you should be if you had disease. We found instead that patients at high risk seemed to benefit or did benefit from taking therapies that lower cholesterol, and the treatment that came out as the standard were statin medications. And there were 4 groups that benefited: those that had known disease, those that had familial high cholesterol, those with diabetes that were at a higher risk with diabetes, and then a final group were people that did not have known disease but had high risk. And we then issued that report. That involved the use of a new risk calculator. And the risk calculator previously used in determining who might benefit was developed from Framingham, which, as we know now, our country is a beautiful mosaic of races and ethnicity. We're not just white Caucasian from Western Europe. And so this new calculator includes information on African Americans especially. It also includes stroke, not just heart disease. So it allows us to do a better job of determining who might be at risk. Now, throughout this work, the one thing which did hold true, even though we were not able to find in 19 different studies a randomized clinical trial that proved that there was a definite LDL level, was that lower LDL was better. And one can look at a number of observational studies showing that as cholesterol, especially LDL cholesterol, increases, the frequency of coronary heart disease, ischemic heart disease, and stroke go up. And so that then leads to the question of if we intervene either by diet or therapy, will people have fewer events? We did indicate that fundamental to any decision about therapy should be a patient-physician discussion. And I want to emphasize that. At one point when we published the new guidelines, I was asked, boy, this new risk calculator looks really good. You just have 8 things that you can plug into a telephone and it'll tell you what you should do. My answer is not so fast on that. Doctors and patients should decide on what's done, not computers.
Well, let me interrupt you there, if I may, Dr. Smith, because one of the things that has puzzled us as we look at the calculator is basically age becomes extremely important, and that virtually all men over the age of 63, regardless of diet, regardless of blood pressure, regardless of cholesterol levels, are told that they really need to be on a statin, and virtually every woman over the age of 70. So you could be a man, 66 years of age, perfect weight, run 5 to 10 miles a day, vegetarian, in phenomenal health, and the risk calculator would say, you're a candidate for a statin, suggesting your point that it's really essential for physicians and patients to have this conversation and not just follow some numbers.
Absolutely. I think when you get into developing risk calculators, age does become important because the older one gets, the more likely they are for a given level of risk factors to have a heart attack or stroke. So it is very, very important not to let the calculator run the show. I've actually seen 3 patients, 2 women and 1 man, who came to me because they knew that I was that I was the type of person that was very interested in diet and lifestyle. They've been told they should be on statins based upon their LDL cholesterol. They hadn't even had the risk assessed. All 3 of them I told I did not think they should be taking a statin. When you get to a risk level of, say, 7.5% with either a white or an African American, and again, this calculator, we're working on the Asian population, which it does not do a good job on because we don't have the population represented, and also the Hispanics. But if you have African American and white, it can do a relatively good job of saying you're at mild, moderate, or high risk. And in the moderate risk group, all 3 of these patients, I told I did not think they needed to take a statin. And we had a discussion, and they were older. 2 of them I did coronary calcium scans on. 1 of them had a score of 0. There's no way in the world that I would recommend treating somebody like that who was 68 years old and had a risk, it was at that level, to take statins. So I think that the calculator can be helpful in terms of identifying people. One of the situations that's so difficult is to talk with a family at 3 a.m. in the morning. You've been in the cath lab and you've got a stent in the artery, and the family looks at you and says, couldn't something have been done? And your answer is, if only we had known. And the leading cause of death in the country today, of disability, heart disease, and stroke, we're missing people. And that came out as we began to look at the 19 different trials, over 170,000 people. There were 3 trials in primary prevention which were particularly good. The Jupiter trial, of course, being the biggest of which, where we found that people whose risk would have indicated they should not have been treated did benefit from treatment, in this case, statin therapy.
You're listening to Dr. Sid Smith, professor of medicine at the University of North Carolina School of Medicine. He's past president of the American Heart Association. Dr. Smith has chaired or served on numerous committees establishing guidelines for preventing cardiovascular disease. After the break, Dr. Smith will tell us more about how to prevent heart disease in the first place.
What side effects should patients watch for when taking medication for heart health?
Does lifestyle play an important role?
You'll also hear from lipidologist Robert Dubroff about high cholesterol and high triglycerides.
What is the connection between cholesterol and heart disease?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com. Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. 800-345-7339. Online at uttercream.com.
If you would like to order a CD of this show, you can call 800 800-732-2334. Today's show is 1053. That number again, 800-732-2334, online at peoplespharmacy.com.
We're talking today about how you can help your heart stay healthy. How much should you exercise? What should you eat? And should you be taking a statin drug to control your cholesterol?
Our guest in this part of the show is Dr. Sid Smith, professor of medicine at the University of North Carolina School of Medicine. He's past president of the American Heart Association. Dr. Smith has chaired or served on numerous committees establishing guidelines for preventing cardiovascular disease.
Dr. Smith, you've mentioned that looking at statins for primary prevention shows that it can be helpful. What do we mean by primary prevention?
Well, it's a good question, Terry. Primary prevention generally deals with those individuals who have not had a heart attack and have no clinical evidence of coronary or vascular disease. So what we're trying to do is to prevent the first event or prevent progression of disease to a point where patients get symptoms.
And, of course, we have heard of secondary prevention, which is somebody who's already had a heart attack or a stent or has clear evidence of heart disease. But that gets us into this whole controversial area of relative versus absolute risk. So in one of the big trials involving atorvastatin, Lipitor, and in fact the company even advertised the drug this way, they said, well, this is a relative risk reduction if you take our drug for several years and you're at high risk, you've had an event, secondary prevention, we can reduce the risk of another heart attack by about a third, 36%. And isn't that great? And most people would go, hey, yeah, 36%, sign me up. But if you look at absolute risk, it's a reduction from 3 heart attacks out of 100 in the placebo group to 2 heart attacks out of 100 in the Lipitor-taking group. And that's probably reflective of statins in general. And so that's actually one person who benefits out of 100. So can you add your cardiology perspective with an understanding of this difference between relative versus absolute risk?
Well, it's very important to understand what you're saying, Joe, because 33% sounds great, but if you're saying you're changing from a 3% risk to a 2% risk, that needs to be included in the discussion. And you need to look at how many patients, the number needed to treat, how many patients would need to be treated for that to have a really significant benefit on the population. Usually 50 turns out to be one of the NNTs that's frequently quoted. So it is extremely important, as you point out, not to be mesmerized by a percent reduction in relative risk, but actually look at the absolute difference that it makes. And that is another reason for the patient-physician discussion. Now, as we looked at the studies, it was very clear that particularly with the higher dose statins up to the age of 75, that the benefits in people who had known disease, so we get to secondary prevention, that is, you made it through one event, let's try to keep you from having another one. We want to prevent that second event. That the high-dose statins in people with known disease resulted in significant reductions at the population level of additional events. And those in general would play out at a number needed to treat, which would be considered appropriate in medicine. But when you get over to Terry's side of the table with primary prevention and you get into people that are at lower risk, it becomes harder and harder to know exactly when to intervene.
And here is something that might make it even more difficult and is absolutely critical, I would think, in that discussion that you are having with your patients. And that's the issue of side effects. Some people don't notice any particular side effects from statins. That's great. What about the folks who do, who come to you and say, Dr. Smith, I'm having trouble with this medication?
Yeah, well, that's a very important point, and my response to that is listen to the patient. The first thing that any good physician needs to do is to listen and understand. And if the patient, for instance, comes in and complains of muscle aches, it can be a little difficult because if you're dealing with an older patient population, they not infrequently will have some arthritis, or they maybe not exactly without some aches and pains. And then they get started on statins, and they come back in and they say, my muscles ache. And you say, well, did they ache before? And you say, well, no, I can't really remember. My memory's not as... So you really have a hard time trying to figure out whether or not this is a new complaint related to the medicine or not. What I do at that point is suggest that they stop taking the medication. That's number one. Number two, I do a blood test to see if there are any enzymes released that might indicate that they have active myositis, an inflammation of the muscles, and I see how they do. Do the aches go away, and were the enzymes up? Even if the enzymes are not up, they could have myalgia, an aching of the muscles caused by statins. So at that point, I need to figure out maybe a lower dose would work, or maybe they are not able to tolerate the statins. In my experience, reducing the dose frequently can help. In a number of recent trials, now that we have the PCSK9 inhibitors, the new gorilla on the block for lowering cholesterol, they're looking at how many people are really intolerant to statins. We're finding out that a lot of people who have muscle aches on statins, when given placebo, get muscle aches. So it's very hard to know what the true incidence of muscle ache or side effects from statins are actually occurring. But my number one rule is, if my patient has a problem, I want to know about it, and I generally stop the statin and take steps to see whether or not the symptoms go away. And the areas that I, as a cardiologist, am particularly interested in, number one, the myalgias, the muscle aches. Number two, any cognitive problems that might come up. And number three, this observation that on higher doses of statins, one can see diabetes. And I think that's part of the discussion with the patient. Let's sit down and take some time and find out, do you get muscle aches? What's going on there? And even if we get an idea of what the memory's been like before taking the statins, and take a look at diabetes. Generally, people that have risk factors for diabetes may be the ones that get it. And in general, what our group found was that the frequency of these side effects was relatively low, and that it did not justify saying statins shouldn't be used. They have tremendous benefit. But from my standpoint, if you're the patient, it's not 1%, it's 100%. Even though only 5% or 10% of the population may have muscle aches, if you have the muscle ache, I'm your doctor, I'm going to listen to you, and we're going to start talking. I want to know what you're doing with your diet. I want to know how you do off of the statins. Drugs are good, but they're not perfect, and they certainly do have side effects, and I think the patient and the physician need to understand what these effects may be and be aware of them when they occur. They came before the committee, which has been reviewed by outside groups before even being published, and it's felt that statins in general are safe enough that they should be offered, and for patients that have known cardiovascular disease for sure and that are at high risk.
Dr. Smith, as arguably one of the country's leading cardiologists, you look at the entire patient and you assess all of the risk factors. I remember an article in the New England Journal of Medicine many years ago that said that there are probably over 250 risk factors for heart disease, including psychosocial things like loneliness and anger and hostility and a bunch of other blood factors besides cholesterol. So I'm just curious your perspective on other risk factors, and in particular where you think lifestyle plays a role in reducing this terrible epidemic of heart disease that we're faced as a society.
Thank you, Joe. Lifestyle is number one, and I do not think the answer is to put statins in the water. The answer is to change behavior. The problem is that given the choice between changing behavior and taking a pill, too many people will take a pill and keep on doing the things they shouldn't be doing. But if we look at lifestyle, exercise is phenomenal in terms of what it does not only for the lipids, but for reducing stress, for blood pressure, stopping smoking, maintaining a proper body weight, knowing if you have high blood pressure, and eating a balanced diet. We believe now that the Mediterranean-style diet, rich in fruits and vegetables, and avoid the sugars and the carbohydrates. Do not substitute them. But this type of diet, along with regular exercise, not smoking, this is the answer. The answer is not to be creating more and more expensive medications. Now, we're at a point where there are people who have the disease who will benefit. But if you're asking me, do we need to have this epidemic? And if not, how do we prevent it? It's lifestyle.
Dr. Sidney Smith, thank you so much for talking with us on the People's Pharmacy today.
It's my pleasure. Thank you.
You've been listening to Dr. Sidney Smith, professor of medicine at the University of North Carolina School of Medicine. He's past president of the American Heart Association and served as chair of the Executive Committee for the National Heart, Lung, and Blood Institute, part of the NIH. Dr. Smith was responsible for shepherding the integrated guidelines for the prevention of cardiovascular disease. He also chaired the combined committee that drew up guidelines on secondary prevention for the American Heart Association and the American College of Cardiology.
We turn now to cardiologist Robert Dubroff. We spoke to him a few months ago. Since then, he's retired from his position at the University of New Mexico. Dr. Dubroff has expressed a dissenting view on the topic of cholesterol as the primary driver of heart disease. On our website, you can find a link to his article on cholesterol confusion and statin controversy, co-authored with cardiologist Michel Delorgeril. Dr. Delorgeril led the Lyon Diet Heart Study.
Welcome to the People's Pharmacy, Dr. Robert Dubroff. It's nice to have you back.
Thank you.
Dr. Dubroff, we understand that you are an associate professor of medicine in the Division of Cardiology at the University of New Mexico in Albuquerque, New Mexico, that you are board certified in internal medicine and cardiology, and most particularly, you have a specialty in lipidology.
What in the world is lipidology, Dr. Dubroff?
Well, thanks for the introduction. I know it sounds strange, but lipidology is a specialty of medicine that deals obviously with problems of lipid metabolism. That means cholesterol and other particles that are involved with the process of hardening of the arteries or atherosclerosis. It's not a common discipline. There are not a lot of physicians who are certified in it, but it's an area of special interest to me because I try my best to prevent heart disease as opposed to just treating it or diagnosing it.
So presumably, if someone has an elevated cholesterol and they're worried about it, or high triglycerides, you're the person that individual might see.
Well, that's true. I mean, not every case needs to be referred to a lipid specialist, but certainly those that are unusual, or when someone has a cardiovascular event at a young age, we're trying to figure out why this happened, I get a lot of referrals of that nature.
And there are people who have a genetic predisposition. I believe your colleagues call this hypercholesterolemia. Is that right?
That's correct. I mean, there are several different genetic abnormalities that can elevate cholesterol or produce what we call a dyslipidemic pattern, a pattern that predisposes the individual to cardiovascular disease. But for most patients, there really may not be a genetic predisposition. It may be more environmental or dietary or other factors.
Dr. Dubroff, we'd like to talk to you about cholesterol, and we'd like to talk to you about the connection between cholesterol and heart disease, because the common understanding is that if your cholesterol is high, you are cruising for a bruising in terms of the heart. There's some reason that we perhaps have put too much emphasis on that, and perhaps some of the recent studies bring that into greater focus. Could you tell us a little bit about that, please?
Sure. Well, this is a big topic and not so simple. In fact, there's quite a bit of controversy And let me just preface my comments by saying I suspect my feelings and opinions are not shared by many other lipidologists. But in any event, the whole story of cholesterol relationship to heart disease is very complex. It starts out with the association of cholesterol, elevated cholesterol, and a higher risk of heart disease. But it also includes the fact that if you look inside coronary arteries and look at the plaque in the artery, there are cholesterol deposits. So based upon those two observations, it seemed pretty reasonable to speculate that cholesterol is a key player in the process of hardening of the arteries or atherosclerosis. And subsequently, people believed that if you lower cholesterol, you can prevent that disease. But my view is that this is a bit of a leap of faith. You're taking what is a risk factor and assuming it is a causative factor, and if you prevent the causative factor, you can prevent the disease. So that is sort of the basis of cholesterol lowering, this concept that cholesterol is associated with coronary artery disease. If you lower cholesterol, you can prevent it. But my view, after reviewing quite a few articles and studying this for years and years and years, is the data is just not that consistent. There's a lot of anomalies to this theory. There are a lot of studies that basically show if you lower cholesterol by several different mechanisms, you don't consistently prevent heart disease and you don't necessarily prolong life.
So it sounds as though perhaps cholesterol is a bystander, perhaps not an innocent bystander, but not the main event.
Well, this is hard to tease out the different components. There's no question cholesterol is a major component and participant in the process of atherosclerosis. But whether or not you lower cholesterol prevents that process, I think that's the part that's unclear, at least in my mind.
You're listening to Dr. Robert Dubroff. He's board-certified in internal medicine and cardiology with a specialty in lipidology. His article, co-authored with Dr. Michel de Lourgeril, is titled Cholesterol Confusion and Statin Controversy. It was published in the World Journal of Cardiology, and you'll find a link to it from our website. We recognize that Dr. Dubroff's perspective is not shared, as he said, with all other cardiologists. In fact, it's a bit controversial.
We need to take a short break, but when we come back, we'll talk more about studies on how what we eat affects our cholesterol and our heart health.
We'll explore some studies that seem to undermine the cholesterol theory of heart disease.
What do other doctors think about this possibility?
You'll also learn about some common side effects associated with statin medications.
What does Dr. Dubroff recommend for his patients who are at risk for heart disease? And how can the rest of us keep our hearts healthy?
You're listening to The People's Pharmacy with Joe and Terry Graydon. Thanks for listening to this podcast of The People's Pharmacy. If you like it, why not rate or review it in the iTunes store? We'd appreciate it. Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of Utterly Smooth Foot Cream with shea butter, helping dry, cracked feet feel utterly soft and smooth. The number is 800-345-7339, online at uttercream.com.
If you'd like to order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1053. The number again, 800-732-2334. Or find it online at peoplespharmacy.com.
Today we are considering the steps we can all take to keep our hearts healthy and strong. Cardiologists agree on much of what we should be doing, but there is some controversy over the significance of cholesterol and how many people should be taking statin-type cholesterol-lowering drugs.
We're talking with Dr. Robert Dubroff. He recently retired from his position as Associate Professor of Medicine in the Division of Cardiology at the University of New Mexico in Albuquerque. He's board certified in internal medicine and cardiology and has a specialty in lipidology.
Dr. Dubroff, there have been lots of what are referred to as observational studies. So these are studies where people are asked to remember what they've been eating. You know, did they have a steak, or are they eating lots of fruits and vegetables? And there are always questions about how good people can remember what they've eaten. And some of those studies have shown that, you know, eating a low cholesterol or a low-fat diet was beneficial, but others maybe not so much. And the real gold standard when it comes to this kind of dietary research are what we call the randomized controlled trials, where you actually, you know, have one group eating a certain kind of food and another group eating something else. And they did this in Australia many, many years ago, back, what do you think, Terry, in the 1960s? And they randomized people who had had heart attacks, so they were really primed for another one. These are high-risk patients. And half of them got their standard saturated fat diet. The other half of them got a diet high in vegetable oil. And the same kind of study, but even bigger, was done in Minnesota, the Minnesota coronary experiment, where they divided the individuals, these were institutionalized patients, to either saturated fat, their standard fare, or this very high corn oil diet. And they were able to lower cholesterol dramatically in those studies, but it didn't have much effect. And that's not the only kind of research of this nature. Can you kind of put all of these randomized controlled trials into perspective and tell us what we've learned?
Well, let's talk about diet first. Part of the rationale for lowering cholesterol was the observation that people who eat a very low cholesterol diet seem to have less heart disease. And this is true if you look at some isolated populations, indigenous Indians in Mexico, some people in New Guinea. These communities, which really live primarily off the land, primarily vegetarian diet, these people rarely, if ever, develop heart attacks. So it seemed, or at least people assume, that, well, if you lower your cholesterol to comparable levels, then you can prevent heart attacks as well. So this has led to other studies and the initiation of these randomized trials of diet. And in these studies, you try to randomize a large population to either, for example, a low-fat or low-saturated fat diet versus a control or regular diet. The problem, of course, is it's very hard to measure adherence to diet. People may say one thing, they may practice a different thing. So there are several limitations of these sorts of studies. Nevertheless, my recollection is that in total, none of these studies have definitively shown that if you reduce your cholesterol intake by diet, you necessarily reduce your risk of having a heart attack, nor do you necessarily prolong your life.
Dr. Dubroff, I'd like to talk a little bit about the role of cholesterol in the body. I think for a great many Americans, Mr. Cholesterol was the bad guy, the evil character that would pop up in the middle of dinner. And we've certainly learned about bad LDL cholesterol. But it seems like there must be a role for cholesterol. I mean, does it have a physiological function? And by lowering cholesterol as effectively as we can with some of our newer drugs, do we run the risk of problems?
Well, there's no question cholesterol is actually essential to human life. We sometimes forget that. It's always described as a bad player and a contributor to heart disease. But the fact of the matter is we couldn't live without cholesterol. Among the many functions, cholesterol is a critical element of cell membranes. Cholesterol is a precursor to many important chemicals in our body, hormones, sex hormones, bile salts. It's involved with nerve conduction. That may somehow connect with the potential risk of dementia with statin therapy. So cholesterol is essential to life. And as a result, there's always going to be this risk-benefit of lowering cholesterol. Are we doing good or harm by lowering cholesterol?
I think that, if there are so many studies that undermine the theory that cholesterol is the principal bad actor in heart disease. And then we have these contradictions, these anomalies, these odd outcomes that shouldn't be happening. One would think that cardiologists would begin to rethink the theory. That doesn't seem to be happening.
Well, actually, it is starting to happen. There are many websites and groups and informal discussions of physicians who are starting to challenge this opinion. But let me make a few other comments and reference a few other studies. Over the years, there have been several drugs developed which lower cholesterol, which have been tested to see if they can prevent heart disease. Statins are the most widely known, and there are literally dozens of statin randomized trials that have attempted to prove taking a statin prevents heart disease or prolongs your life. But in addition, there have been several other classes of medications. For example, there's a class of medication called fibrates. Fibrates lower cholesterol. They also lower triglyceride. They also raise HDL. But the studies of fibrates have been very inconsistent and predominantly failed to show a benefit. So there's a long list of different drug classes that have been tested, but statins have sort of withstood the test of time because in addition to these negative studies, there are many studies which have definitely shown a benefit. And I think this has led to a concept that maybe it isn't the cholesterol-lowering effect, maybe it's some other effect of the statin. Sometimes we refer to this as pleiotropic effects. We know that these statin drugs can do many other things aside from just lowering cholesterol. They can minimize inflammation. They can favorably affect blood coagulation. There's a variety of things, antioxidant effects. So it may be that statins have benefits that are simply not attributable to the cholesterol lowering, and that may be why statins are still so widely recommended and still show benefit in many studies.
Dr. Dubrow, statins certainly do have benefits. They also have some drawbacks. One of the drawbacks is that they tend to raise people's blood sugar. Can you tell us about the statin diabetes conundrum, please?
Well, a few years ago, the FDA issued a new set of warnings that's now reported on the package insert of all statin drugs. And there were two things that they made note of. One, there seems to be a higher incidence of cognitive decline or dementia in people who take statins. This has really been difficult to prove. But nevertheless, the totality of evidence persuaded the FDA that they needed to include this warning. And I can tell you as a practicing cardiologist, I see many patients who are convinced that their poor memory is attributable to the time they started taking statins. That doesn't prove it, but I think there's enough observational information to make it a concern, and certainly it should be discussed with patients before they start a statin therapy. The other big issue is the risk of diabetes. This issue has been highly controversial. People are very opinionated onto whether or not statins cause or prevent diabetes, and there have been many analyses that have been published on this topic. And almost all of them have concluded that the risk of developing diabetes is very minor, especially when you compare it with the potential benefits. But when I researched this area in a bit more detail, what I found is almost all of these conclusions were based upon short-term studies, typically those studies which were only 4 or 5 years in duration. The problem is most patients who are prescribed a statin drug are prescribed statin drugs essentially indefinitely. So it turns out a few years ago, some researchers in England looked into the national health records of patients taking statins for many, many years. And what they found is the risk of diabetes gradually went up the longer you were on the drug. And if I'm not mistaken, for patients who were put on a statin for at least 15 to 20 years, the relative risk of developing diabetes went up something like 363%, which is definitely not trivial. Diabetes, of course, can potentially lead to cardiovascular disease. So it seems ironic that the disease we want to prevent, we may actually be contributing to somewhat with statin therapy.
What are the most common statin side effects besides the ones you mentioned with regard to memory?
So the most common side effect, at least in my practice, and I think most physicians, is muscular aches and pains. This has really been sort of the Achilles heel of statin drugs. There's no test for this. It's very subjective. There's always a chance that it could be sort of a placebo effect. In other words, you talk to your patient, you say this drug may potentially cause muscular aches and pains. A month later, they're saying, I'm having aches and pains. The only way you can find out is to stop the drug, which in itself is not a perfect experiment. But if you stop it and the aches and pains go away, then you assume the two are connected. This has been an issue for many, many years and has prevented many patients from staying on their statin drugs. These muscular aches and pains can take many forms. Most commonly, people will describe like a flu-like illness, stiffness, soreness in the muscles, especially the legs. But I've had patients who have been misdiagnosed as having spine problems, neck problems, all kinds of musculoskeletal issues that all went away when the statin drugs were stopped. Now, there's a continuum of muscle problems. The most benign form is what we call myalgias, just pain in the muscle. But a small percentage of patients who take statin drugs will develop a life-threatening condition, which is called rhabdomyolysis, where there's actually breakdown of muscle. It can lead to kidney damage and actually death if it's not diagnosed and treated early. Fortunately, that's very uncommon.
Dr. Dubroff, as a cardiologist, what you want to do is keep your patients from having heart attacks. I'm assuming that there are a number of possible approaches that patients could take to this goal. Can you tell us about some of them, please?
Definitely. I think in general, the way most cardiologists approach prevention of heart disease is to look at risk factors. Some risk factors you can treat, and they're definitely beneficial. Some risk factors you can treat, such as cholesterol, and in my view, it's not entirely clear. But for example, we know high blood pressure is a major risk factor both for heart disease and stroke. And I think the evidence, based upon numerous clinical trials, is quite clear that if you control blood pressure, you can definitely reduce the risk of a heart attack or stroke. So blood pressure control is extremely important. Smoking cessation is extremely important. There's no question smoking increases your risk for cardiovascular events, and stopping smoking can reduce your risk. So these things are pretty straightforward. Just going on a low cholesterol diet, as I've mentioned earlier, I'm just not convinced that's ideal. In fact, there's some evidence that the food industry, responding to this need to lower cholesterol and use low-fat, low-cholesterol foods, has instead given us a lot of food that is high in sugar, refined carbohydrates, preservatives, etc. And there's some evidence that eating these sorts of foods has led to this epidemic of obesity and diabetes, which of course can then lead to heart disease. So diet is a tricky issue. I again fall back to the Mediterranean diet simply because there's evidence out there showing that people who adhere to a Mediterranean diet are at much lower risk for developing heart disease. There's also some evidence that people who follow a Mediterranean diet are less likely to develop cancer, Alzheimer's, and even diabetes. So there are a number of benefits to a Mediterranean-style diet.
Dr. Dubroff, as you review the history of treatment for either preventing or dealing with heart disease over the last 50 or 60 years in America, what is your message both to patients and other physicians in terms of moving forward, the lowest risk, the greatest bang for the buck? What would you like to see people doing to prevent the number one killer in America?
Well, I think in this area, most physicians and I agree that lifestyle is the most important thing we can do. There have been numerous studies now that have shown that if you follow a healthy lifestyle, you can greatly reduce your risk of dying from a heart attack. A healthy lifestyle means several things. One, regular exercise. I don't think it has to be running marathons. It can be walking, but something that you can do most days of the week for at least, say, 30 to 60 minutes each time. Two is no smoking. There's some excellent data from California showing that the reduction in heart disease over the last 20 years in California correlates extremely well with the reduction in smoking. So stopping smoking is a key element. The third element is avoiding obesity. We use a measurement called the body mass index. In general, it should be below 25. If patients can maintain a BMI, body mass index, below 25, that's a very important guideline. And the last thing is a Mediterranean-style diet, avoiding processed foods, avoiding fatty foods, avoiding fast foods, primarily eating fresh food, lots of fruits and vegetables, whole grains, olive oil, nuts, avoiding meats, avoiding most dairy products, consuming some seafood and fish.
That sounds like a great prescription for a wonderful life, and it's good to know that it can help keep our hearts healthy.
You know, it's not new information. I think we live in a society where it's just hard to do. We all have busy lives. We're all trying to rush through meals. It's easier, faster, and sometimes cheaper not to do this. But if patients make the effort to do those 4 things, I think the results are very, very beneficial.
Dr. Robert Dubroff, thank you very much for talking with us on the People's Pharmacy today.
Thank you, and thank you for inviting me.
You've been listening to Dr. Robert Dubroff. He recently retired from his position as Associate Professor of Medicine in the Division of Cardiology at the University of New Mexico in Albuquerque. He's board certified in internal medicine and cardiology with a subspecialty in lipidology. You'll find a link to his article on cholesterol confusion and statin controversy on our website.
Earlier in the show, we spoke with Dr. Sidney Smith, professor of medicine at the University of North Carolina School of Medicine. He's past president of the American Heart Association, and he served as chair of the executive committee for the National Heart, Lung, and Blood Institute.
Lynn Siegel produced today's show. Al Wodarski and Robin Copley are our engineers. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible in part by Red X Industries, makers of Utterly Smooth Extra Care 20 cream with 20% urea for extra skin protection. The number is 800-345-7339. The website is uttercream.com.
To order a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show, 1053. That number again, 800-732-2334, online at peoplespharmacy.com.
When you visit our site, you can check out information on prescription drugs, herbal medicines, and home remedies. Share your thoughts on today's show. What are you doing to keep your heart healthy? You'll find a link to our extended interview with Dr. Dubroff at peoplespharmacy.com.
And when you visit our website, you can sign up for our free online newsletter or the free podcast of the show. You can listen at your own convenience or share it with a friend at peoplespharmacy.com. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.
If you love chilling mysteries, unsolved cases, and a touch of mom-style humor, Moms and Mysteries is the podcast you've been searching for. Hey guys, I'm Mandy.
And I'm Melissa. Join us every Tuesday for Moms and Mysteries, your gateway to gripping, well-researched true crime stories. Each week, we deep dive into a variety of mind-boggling cases as we shed light on everything from heists to whodunits. We're your go-to podcast for mysteries with a motherly touch. Subscribe now to Moms and Mysteries wherever you get your podcasts.